So, continuing with amblyopia. Amblyopia is also known as the lazy eye. It is a poor vision. For example, consider my right eye to be amblyopic eye. It is a poor vision in that eye, which has failed to develop the normal sight during the early childhood, that is the early infancy up to 6 months of age, when the main visual development of the eye is there. Up to the brain, the connections, the signals are going to the brain, or up to the 3 years till the vision matures. If up to 12 years, they say that the visual pathway matures even up to 12 years of age. So the amblyopia can occur at any age up to the 12 years of age. It is a lazy eye. It is a poor vision in the eye that fails to develop the normal sight during an early childhood. And this is usually caused by the use of that eye because the brain has learned to favor the other fixating eye. That's why this lazy eye, the brain starts ignoring the lazy eye, the signals from the lazy eye. Because the lazy eye doesn't send the signals, the brain starts ignoring it, and with time this becomes permanent. To protect the child's vision, amblyopia or the laziness should be corrected during infancy or the early childhood. Mostly up to 12 years of age we correct the amblyopia. Some books consider even 9 years of age. Okay. What are the various causes of amblyopia? There are the 4 main causes, of which the strabismus is the most common cause of amblyopia, and this often occurs in the eyes that are not aligned properly or are crossed. The crossed eye turns off, that is, doesn't send signal to the brain to avoid the double vision because of the suppression, and the other eye, which is not crossed, that is the fixating eye, takes over most of the visual function. Because the brain favors the fixating eye over the amblyopic eye, the non-preferred eye, that is the amblyopic eye, is not adequately stimulated, and therefore the brain cells responsible for the vision in the amblyopic eye do not mature normally. That is, the ocular dominance columns of that eye do not mature, and hence the amblyopia results. Anisometropia is the second cause of amblyopia, and it refers to the condition where the eyes have unequal refractive power. For example, I might be using -1 diopter in this eye and about -6 diopters in the other eye, and this is referred to as anisometropia, that is, the two eyes have unequal refractive power. For example, one eye may be nearsighted, that is myopic, and the other farsighted, that is hypermetropic. This is an example of anisometropia. Amblyopia. When does amblyopia occur due to anisometropia? When the brain cannot balance this difference and chooses the easier eye to use, and mostly after 3 years of and mostly if the distance between the two eyes is plus or minus 3 diopters, amblyopia may result. Both the eyes appear normal, but because the brain is using only one eye most of the time, the other eye has poor vision due to amblyopia. And this type of amblyopia is very hard to detect because eyes appear normal but still the vision is down, and therefore this requires very careful measurement of vision and fundus. The third cause of amblyopia is any eye disease or any injury that prevents a clear image from being focused inside the eye. An example of this can be congenital cataracts, which causes the clouding of the natural lens of the eye, and the rays cannot reach the retina, and hence the maturity levels are not reached. How can we treat this amblyopia? Treating the cause of amblyopia alone cannot cure the amblyopia. Amblyopia is the immaturity of the visual pathway. Okay, and correcting the cause doesn't cure amblyopia. Amblyopia will still be present even if we correct the cause, and therefore the treatment always requires forcing the brain to use the non-preferred or the non-fixating eye. For example, if my right eye is fixating and left eye is strabismic, I will close my right eye and force the left eye to look into the object. By patching the normal eye for most part of the day or some part of the day, often for weeks or months continuously, the brain must be able to use the weaker eye. Even after the vision has been restored in the amblyopic eye, patching may be necessary to maintain the improvement. We will penalize or patch the fixating eye so that the brain is forced to use the non-preferred eye and hence the visual pathway of that eye matures. To correct the errors in focusing or to balance an unequal refractive power between both the eyes, glasses must be prescribed. On an occasion, special eye drops such as atropine or any cycloplegic or lenses or high plus lenses are used to blur the vision in the good eye, forcing the use of the amblyopic eye. If a cataract is causing amblyopia, the cloudy lens must be removed before the other eye has to be patched, otherwise it will be no use and bilateral amblyopia can result. And following any surgery, the patient may wear the prescription eyeglasses or the contact lenses to restore focusing, while the patching improves the vision. Next, we will look onto the workup of a case of a squint. What all examinations we have to do when a patient of strabismus comes to us. First is a history taking. We have to focus on the presenting complaints, whether it is a asthenopia, that is a headache over the forehead, or there is diplopia. What is the age of onset, whether it is since long duration, present since childhood, or it is a constant angle, or the angle varies, or the angle of the strabismus varies. If there is a constant angle, the prognosis of gaining the vision is poor, but still cosmetically the eye may be straightened. But still, the side effect of diplopia still looms over the surgeon and the patient both. What is the pattern of deviation we have to look, whether it is intermittent, that is appears sometimes when the eye is fatigued, whether it is constant or it is alternating. We have to look for any change in the head posture of the patient. We have to look for the old photographs of the patient to see the change in the head posture. We have to see if there are any precipitating factors which precipitate this strabismus. We also have to ask about the antenatal history, the perinatal factors of the child. We have to see what treatment already has been given, whether refraction has been suggested, glasses, any occlusion or patching has been given, or surgery has been done. Refraction of the patient, especially the children, has to be done under proper cycloplegia, and objective refraction has to be relied on than the subjective refraction, especially in children. And deviation is measured only after some time of correction of the refractive error. Any strabismus should not be operated without measuring the deviation with the glasses. This is the rule. We have to always refract first. If after refraction still there is a strabismus remaining, then only we should operate, otherwise we should not operate. We have to examine the interior and the posterior segment. In the interior segment, what all we have to examine, we have to look for any lid abnormalities, especially the ptosis, any media opacity such as the cataract or the corneal opacity, the pupillary reflexes. We have to look for the pupillary reflexes. Pupillary reflexes can help us, like if there is an apparent pupillary defect present, we can look for the cause of the strabismus as being sensory. If there is the direct pupillary reflexes are okay, there is no APD, but still like if the third nerve is involved, even the pupillary reflexes, the indirect pupillary reflex will be lost. We have to see the site and type of fixation, which eye is fixating, and whether it is cross fixation is present or there is no cross fixation present. We have to see that. We also have to measure the torsion. In the measurement of the torsion, we have to remember we can measure the torsion either by using a Maddox rod test. We will come to it. Maddox test, any fundus photographs, but the diplopia charting can't be used to measure the torsion. It is just a qualitative test. Diplopia testing can only tell us that torsion is present, but it cannot measure the torsion. Torsion can be measured using the Maddox rod or this fundus photographs. Okay. The next is the assessment of the visual acuity. Visual acuity in adults is done using the Snellen's chart. We all have seen the Snellen's chart in the OPD. This is a Snellen's chart with the first curve of 6 by 60. The 6, what is 6? It is a distance. It is a distance from which the numeric to 6 is the distance from which we tell the patient to sit and see this. And 6 by 60 means the distance as the 6 meter at which this is seen. The person must be able to see that same object even if it is sitting at 60 meters based on the angle formed on the eye. The angle which is formed at 60 meters is formed at the 6 meters of the patient if the vision of the patient is 6 by 60. How is visual acuity in children measured? By the preferential looking tests. That is a Teller's acuity test as shown in this. There will be stripes and the child will prefer to look towards the stripe side and not the other side. Any Cardiff acuity test, any Catford drum test, and visual evoked responses, etc. These stripes will increase in width and decrease in width, and accordingly we can guess the child's visual acuity. What is true or pseudo strabismus? Always before labeling the patient as strabismus, we have to rule out pseudo strabismus. Pseudo esotropia, like in this case, the corneal reflexes directly over the pupil, but the patient has pseudo-esotropia. In the pseudo-esotropia, the causes can be the epicanthus, as in this patient, any telecanthus, any euroblepharon, any negative angle kappa. Causes of pseudo-exotropia are hypertelorism, when the orbits are outside, any positive angle kappa. What are the causes of pseudo-hypertropia? The cause is ptosis. Detection of squint. Detection of squint can be done with the cover-uncover test and the cover-uncover test. And the prerequisites for doing a cover-uncover test are: the subject should be able to fixate the target with one eye, central fixation should be there, and no gross motility defect should be there. Only then cover-uncover test has to be done. Otherwise, if there is any gross motility defect like ophthalmoplegia or paralysis, cover-uncover test is not much useful. In the cover test, a cover is placed briefly over the eye which appears to fixate. For example, if my right eye is fixating, I will put the cover over my right eye, and it should be done for the distance separately and for the near separately, and it detects any manifest squint in the other eye. And the limitation of this test is gross eccentric fixation with heterotropia is not detected, and this also does not detect any microtropia. In the uncovered test, which is used to detect for latent strabismus, if my right eye was a strabismic eye and I had covered it, and I will just remove the cover, what all observations I have to make? I have to see the speed of recovery of the eye, which eye is dominant, and whether there is any free alternation present between the two eyes. After doing the cover-uncover test, we should do the ductions and the vergence. Ductions, what are ductions? They are the uniocular movements in all the directions of the gaze. What are vergence? They are the binocular, that is the movements of the two eyes together in different directions of gaze. We have to measure the ocular deviation in the strabismic patients, which we will continue further in the next video.